presentations were very informative and helpful. In today's presentation, I will refer to two cases of our department that we manage physically, and I will need your comment and assistance to facilitate the discussion. The first case is a 77-year-old man who presented in the emergency department with a lower limbs weakness for the past 3 weeks, and his condition progressively worsened, and he has also reported urinary disturbances. He has no significant past medical history. On the clinical examination, he had muscle weakness in both lower limbs, spasticity and increased reflexes in the lower limbs, urinary retention, and he had the loss of the sensation in the perineal region. If this patient is presented to your emergency department, what emergent condition does he most likely have? And what is the imaging study of the choice, of course? Can you tell me something?
I mean, anybody who we can switch on your audio and you can speak if you like, unless you are asleep or you fall asleep.
Okay.
We don't have so many volunteers on us, I'm afraid.
Okay. These findings are highly suggestive to the conus medullaris syndrome, and the investigation of the choice is urgent for using a lumbar MRI to identify the etiology. Luckily, the patient had already undergone an MRI when he first came to the hospital. It's quite difficult to perform an emergent MRI in our hospital. Could someone describe what we are seeing? Okay.
Anybody? I will try. I'm gonna open the microphones. Maybe in the chat or something. So you don't know what may this happen, maybe this be.
Okay.
Okay, it's hopeless, Thanasi. Go on.
On the MRI lumbar spine, there is a lesion at the level of L1, intradural extramedullary in location, showing.
Okay. Give us a clue. Give us a clue. What could it be?
Intradural. There is no on the medullary in location. In the T1, can you see the low density on T1? And in the contrast enhanced is the third images. Can you see the enhancement? Casing the significant compression and displacement of the conus medullaris. So, what will you include in the differential diagnosis for this lesion? First of all, in the differential diagnosis, we can include the myxopapillary ependymomas, which is by far the most common tumor of the conus medullaris and epithelium terminale, representing up to the 80% of the tumors in this region. The second one is the schwannomas, which is the second most common tumor in this region. And other tumors like the meningiomas or metastases or other like the paragangliomas, and or non-plenoplastic mass lesion like the epidermoid, dermoid cyst, and intradural disc herniation. About the treatment, the patients underwent a laminectomy of T12, L1, L2, and complete excision of the lesion. Post-operative, the patient the patient's muscle weakness improved, but the urinary dysfunctions persisted. The onset of the perineal anesthesia and the bladder dysfunctions is the time at which the clock starts on the diagnosis and management. And the urinary retention has the greatest predictive value as a standalone symptoms, but is indicative of late and irreversible. About the results of the histopathological examination was meningiomas. In our case, it is not typical image of meningiomas because there is no dural tail, which can be seen in the up to the 60% of the spinal meningiomas. The spinal meningiomas is one of the two most common intradural extramedullary spinal tumor, which represent up to the 30% of all such tumors. But meningiomas in these regions are very rare. They represent only the 2% of all spinal cord meningiomas, with the thoracic region is involved far more often, up to the 8%, and followed by the cervical region. And most of the meningiomas are benign, with up to the 90% being classified as a grade 1 lesion. That's from the first case. There is any comment or something to? No.
Okay.
The second case.
Before we go on with the second case.
Okay.
Is there any, to your knowledge, is there any other symptom that the tumor of this region can be presented? Apart from, signs from legs and sphincters, and stuff like that. Do you know anything else that can be?
As Mr. Badal has already
in these
pointed.
cases, in this case, in tumors of the cauda equina or the conus medullaris, as in this case, some other symptoms also can be evident. Intracranial symptoms? Is there anybody who has heard anything like that? So just to know, there are cases of tumors of the region who are presented with hydrocephalus. And this comes because of the high density of these kind of tumors in proteinic fluid, which actually can lead to hydrocephalus, or even in some cases like the ependymomas that we showed before, because of the lesser volume of the CSF, because of the space occupying phenomenon. Have you heard anything like that? We had a case in our clinic, I think, paraganglioma, about a couple of years. So just to know, sometimes patients with this kind of tumors, because they are very slow growing, I'm not talking especially about meningiomas, but especially for paragangliomas or myxopapillary ependymomas, they present with symptoms of intracranial pressure. Okay. Go on to the second case. Yes, please, Thanasis.
Yes, thank you. The second case is a 57 years old man who presented with low back pain and sciatica in both legs for the past month. Over the last week, he developed a perineal numbness. He passed medical history, include chronic lymphocytic leukemia. On clinical examination, he had no muscle weakness. The reflexes were normal, with the pain along the lateral aspect of both thighs, mainly on the left. Loss of the sensation in the perineal region, and without urinary retention. So, what conditions does he most likely have? These findings are highly suggestive of the insufficient caudal inguinal syndrome. And what is the imaging of the study of the choice? Is MRI, and on MRI we can see the central disc herniation was depicted. Okay.
So what are we thinking about that?
Okay, nobody. So
apparently, Thanasis, you are going to answer.
Due to the location of the disc and the perennial medical history, we also perform a CT scan. And on the CT scan, revealed that the lumbar disc was ossified.
Okay.
So, based on your experience, Mr. Barkas, I need your help now. Which surgical approach will you choose for these patients and why? Lateral approach, lateral approach, or lateral approach?
Kostas, are you with us?
Yes, of course. I mean, you can do whatever one thinks. In spine, there are many options. But in my experience, since this is slightly below the cauda equina, you could easily go from posteriorly. And I think that the transpedicular approach, though, should be advocated so that you can have a very good decompression and go from posterolateral and try to remove as much of the disc out. Since it's calcified, it's more likely that it's not going to come out. So a wide posterior decompression would be good enough, I think. But if you take the facet out, then most likely you'll need some kind of fixation. I wouldn't go anteriorly in this because of as you can see in the axial images, the kidneys are there. So doing a lateral approach so that you can go frontally to the conus, it's slightly difficult. It's not like the thoracic spine where you can more easily approach the lateral part of the vertebral body.
Okay, so you Kostas, to your opinion, would you change your attitude if this was not an ossified disc, if this was a soft disc? Would you change your attitudes?
If it was a soft disc, then I would definitely start with a unilateral decompression, so a hemilaminectomy, for example, not go for a full-blown laminectomy, and try to see if this would come out.
Okay, yeah, I fully agree on that. And it's a nice case because we can we can notice that there was this suspicion of an ossified disc, and that's why the CT scan was also done, wasn't it? Yeah, that was the reason.
Yes.
And as you said, this can change the whole attitude. It can change the operation. It can change what we waiting for the operation. Okay, go on, Thanasis.
Many approaches have been described. Each one has its advantages and disadvantages. We avoid the lateral approach because this was located at the end of the conus, extending more toward to the caudal inguina, and the kidneys were at that level. We perform laminectomy of T12 and L1, a transpedicular approach, and we try to remove part of the herniated disc. And posterior fusion from T11 to L2 was carried out to ensure the better spinal stability. Post-operative, the patient demonstrated full muscle strength in the lower limbs with the pain relief and without the numbness in the perineal region. This is 2 cases of our department. Thank you very much, Mr. Palaiologos.
Okay, so thank you.